I'm very happy to introduce Dr. Bruce Spiess. He's going to speak to us today on bloodless medicine, a superior form of healthcare. And so Dr. Spiess, Dr. Bruce Spiess, to those of you who are not known, is presently an Emeritus Professor of Anesthesiology at the University of Florida at the School of Medicine in Gainesville, Florida. He was born to academic parents and grew up steeped in a research background, with his father actually being a geneticist and his mother a biochemist. Dr. Speece attended Denison University in Gainesville, Ohio, and they just actually bestowed upon him in 2017 their highest honor, the Alumni Citation for his research work in medicine. He attended Rush Medical College in Chicago and followed by the Mayo Clinic for anesthesiology training, where there he specialized in cardiothoracic anesthesiology and was a chief resident. He returned to Rush for his first faculty position from 1983 to 1990. From there, he traveled on to Seattle, Washington, and there he left Washington State when a business opportunity for his new wife presented itself in Richmond, Virginia. He took the position of vice chairman in anesthesiology at Virginia Commonwealth University in Richmond, Virginia, where he stayed there for 17 years until pursuing his last position at the University of Florida. Dr. Speece has focused his research upon blood, its critical oxygen carrying capacity, oxygen therapeutic pharmaceutical development, previously known to us as blood substitutes, the risk for transfusion, and coagulation, coagulopathies, and the development of monitoring technologies. His extensive work in blood transfusion risk has led him to be an outspoken proponent of patient blood management. He's authored over 200 peer-reviewed academic articles, more than 40 book chapters, 7 textbooks, and has even appeared on the Discovery Channel and many other lay media. His work has been funded mostly by the United States Department of Defense and has led major conferences for the Department of Defense, the National Institute of Health, the FDA, with regard to critical blood issues. As it pertains to patient blood management, Dr. Speece has spoken at SABM a number of times and on every continent, with the exception of Antarctica, where currently blood management is not a great issue. But he has worked with governmental agencies, particularly in Australia, to enhance the support for liberal thinking on blood management. His present work at the University of Florida has a major focus on trying to get that very large medical center to become a showplace for anemia correction, as well as to become a world center for bloodless medicine. Dr. Speece is particularly proud of his involvement with the Special Forces, the United States military, and its efforts to help government agencies understand the issues of when blood is not an option. Dr. Speece has won several awards, including the Award of Excellence of the Bloodless Medicine Surgery Society in 2019 for his excellent contributions to the science and the practice of bloodless medicine and surgery. So what more can we say? With further ado, Dr. Bruce Spiess.
Good morning, everybody. It's so wonderful to see so many people that I know from around the world, and it's very heartwarming to share a common cause with so many of you. It is a common cause. It's a bit of pushing rocks uphill, and I've been doing that for 45 years. And last year, Nathaniel was good enough to ask me, maybe Sharon, a bunch of you were involved with asking me to give the keynote address. And I'm really touched that you came back and asked for me to do a similar talk this year. I think last year, my feedback was that I was a bit outspoken. And Nathaniel has challenged me to consider giving a talk at SABM about the similar kind of discussion. And so over the last year, I've had a great deal of time to think about it and expand in my mind on what I said last year. So if this year's talk is even more outspoken, I'm not going to apologize for that. The point is that bloodless medicine is a superior form of healthcare, and we need to tumble to that as our ultimate goal. Without further ado, let me get going on it. I have a number of disclosures. Perhaps my number one disclosure that I'd like to put forward right now is a bit of an advertisement for you all, that there's a new book that has just come out called Blood Works. And I'm so proud to have contributed to that book. It is perhaps one of the finest books I've ever read on the subject, and I put it forward to so many people that I work with that they really simply need to read it. You can see that I have been involved with a number of companies over the years. None of those I think are going to come into play today. This is where I left off last year as my conclusion, that blood is a complex organ and that we don't really study it, and medicine doesn't really treat it as an organ, and we don't teach it as an organ, and we don't do research on it as an organ with its complexity and its interaction with the vascular system. And Nathaniel and others have already spoken to the point that when we do a transfusion, it's a transplantation. It's an organ transplantation, and we don't do organ transplantations on anybody else until that organ has failed, and that failure of that organ is otherwise going to lead to the patient's death. We give blood transfusions for any number of reasons, and so you have to ask the basic question of do we really know what we're doing? So I think bloodless medicine has or should, it hasn't yet, but it should become the default position for all of us. And patient blood management is an evolutionary step on that towards the idea that bloodless medicine is where we ought to go. This is also from last year. Ecosystems can be beautiful. The complexity of the ecosystems is what I love. And what I love about biology, and I was forced to learn biology by my parents. So it's really is in my bloodstream or in my heart or in my head, that the complexity, and every day, every week, every month, I'm finding some new piece of complexity. Right now, I tend to be diving deep into HIF1 alpha. HIF1 alpha is a protein that in every one of our cells tells every one of our cells whether it has enough of its own oxygen. And so how does that protein work? What's the relationship between that protein and all the other proteins in the body that are regulating oxygen? Fascinating, just absolutely things that 20 years ago wouldn't thought of. So blood and the vascular system on our organ, perhaps the biggest organ in the body. It touches everything, and they're mature and they're balanced ecosystems. And when balanced ecosystems are balanced, they work beautifully. When they become unbalanced, things begin to fall apart. And then you have diseases. And we often, as physicians and medical healthcare professionals, think that by doing one intervention, we can put the entire ecosystem back together. That doesn't make any sense at all, does it? So once the ecosystem is dramatically disturbed, it's hard to restore that homeostasis that is what has evolved over millions and millions of years. So to understand an ecosystem, we must look at both micro events plus macro interactions. And I'll put it to you, when you and I give a transfusion, that's a macro interaction. That's an insult to the entire ecosystem. It's not restoring the ecosystem. It's an insult. Let's try to put out a forest fire by lighting a backfire. Well, once in a while that works, but sometimes it gets out of control and makes things worse. We can't oversimplify, and that's what we've done for years and years and years in medicine. As I said, blood is a liquid organ. It's complex. I'm not going to go into it in so many different ways, but most often physicians focus on just the oxygen transport qualities of blood. And I'll put it to you today that I spent over 40 years of my career trying to understand that. I still don't understand it. And I think the average physician anywhere in the world has a very poor, very limited, and perhaps myopic concept of what oxygen transport really is, how it works, and especially in disease. So red cells are incredibly complex. They've evolved in mammals to regulate tissue oxygen levels, regulate, not the more you give, the more oxygen you get. They are there to regulate. Oxygen is a toxin. Every one of us will die from oxygen toxicity. Chronic oxygen toxicity is what leads to superoxide radical generation, aging, atherosclerosis, inflammation, COVID, go on and on and on. How do our white cells kill things? By superoxide radicals. It's all fascinatingly interactive. So the normal levels of hemoglobin and hematocrit exceed critical needs by at least fivefold. That's a take-home point I want everybody to have. How much red cells you have exceeds your critical point by fivefold. And I'll talk later about how many times you have to hemodilute an experimental animal before you get to that critical level. You don't just hemodilute 5 times. It's a whole lot more than that. So normal hemoglobin and hematocrit levels have evolved, I believe, for regulation of vascular tone, shear stress, nitric oxide flux, signaling, endothelial cells, everything else other than just oxygen delivery. So RBCs are also important to coagulation. I'm not going to go through all the rest of this, but you can begin to see how complex it is. So my new thinking, I've given considerable thought to the subject. I like to hike. I live out in big mountains out in the western part of the United States. So when I seek solace in my life, I get out on the trail and I go up the mountain. I see all kinds of wild animals, occasionally a rattlesnake, something that might scare you. Do tarantulas, all exciting. But during the time that I'm out there, oftentimes I think about the big pressing issues in my mind. And this is a big pressing issue in my mind. How do we change the world's thinking on blood utilization? Unfortunately, in the last year, little has changed internationally, at least in terms of how the world is viewing blood transfusion and doing and teaching and functioning the same way. Allogeneic transfusion is a human behavior. It is not science. It is a human behavior. Every time somebody orders a unit of blood to be hung by themselves or another healthcare worker, they have taken on a human behavior that's a complex end action of belief systems that they have. And that's what it is. It's an end action in response to belief systems. And transfusion has been filled with assumptions. And as I said, this lack of complex understanding. It's a failure to acknowledge the basic biology of this red cell storage defect, which I think Nathaniel also mentions. It's got biases at all levels of research. I'm going to go into some of those biases here in just a couple of minutes, because I think the biases continue to block us from moving forward. And there's been a systemic worldwide blockade of oxygen therapeutic agents leading to regulatory approval. Thousands, tens of thousands of patients have received them safely, and yet the major agencies in the Western world have refused to understand a way to do research effectively showing that their utilization could be useful in patients where blood is not an option. And that is to the detriment of billions of people. I think billions of people have their health care at risk because we, the Western world, has been myopic in viewing our regulations are only for ourselves. Our regulations change the entire world. So the World Health Organization and Axel Hoffman and all the committee that worked with him, and there's a long list of names of people that contributed to this. Thank you so much. This is one of the finest things I've ever read. They made a call for action in October of 2021 or September of 2021, and it lays out the fundamentals of PBM far better than I could. But to my knowledge, since that came out, little has changed. I pound my fist to get people to read this. Say, if you want to read one thing, read this outcome. I've sent it to people in the United States government. to date, nobody's beating down my door saying, how soon can we participate? We're the World Health Organization. Barry A. Shander, myself, many people on this call all joined into a call for why we needed patient blood management with COVID. There was a worldwide shortage of blood available for transfusion when COVID came around. The methodology to take care of that problem was right in front of every government's face. Embrace patient blood management, wholeheartedly embrace it, teach it, force it to be into every one of your healthcare systems like the Australians have and they've done in Ontario and other places. But still, nobody embraced that, even though this was out in the world's literature. Evidence exists from Korea wherein you can trace COVID in one particular patient who went and donated blood, and that COVID showed up in a patient that received the blood transfusion. Evidence directly exists there, and it also exists in China, yet the Western world was unwilling to investigate whether COVID could be transmitted by blood transfusion. I can have that argument with anybody who wishes to have it, but the facts are there. They've wished to have their blinders on and not even investigate it. So here's a book that I would like to recommend to every last one of you to read. We all filter information in every part of our lives. Whatever information you get from news on television, and in the United States, we get bombarded with horrible different levels of arguments for and against all kinds of things. But we all have our believing brains. In other words, our brains are programmed to analyze and accept data based upon our own belief system. And that's absolutely true in science and in medicine as well. I read an article. I either accept the data in the article, and in some articles, I'm far more critical. Why? Because of what I have read before and what I have as a belief system. Having read this one book, I hope I can look a little bit better in the mirror and try to understand my own resistance to believing new data and accepting new people or accepting people's new facts or new visions of the world. But the believing brain is what has driven transfusion for 140 years. And it is the believing brain that has accepted only certain data and only certain protocols and guidelines and such. To those who hold a spiritual belief, it's real. It's a religion. I've coined the term that transfusion is a religion. Think about it. It really is a religion. Medical data are based on prevailing beliefs and systems of the day. Try getting a National Institutes of Health grant. When I went for my first $3.5 million National Institutes of Health grant, I improved outcome after heart surgery based upon whether or not patients were analyzed with TEG and viscoelastic whole blood testing. And I was laughed out of the National Institutes of Health. I was essentially told to please never apply to their granting agency again, because anybody in medicine knew that to use viscoelastic testing, you didn't know anything about medicine. So now there are over 17,000 articles on that test alone. So it's absolutely true that what is a prevailing thought in medicine at the time drives either what gets funded, what gets researched, and what gets published. But it goes further, and it's very subtle. And if you look into individual papers that are published, we repeat certain mantras, and those mantras that get repeated drive and feedback upon the belief system. There's a universal introduction in almost every transfusion paper, especially if the transfusion paper goes on to say things about patient blood management. And that introduction is, And here it is in a very well-known paper by many well-known names, many of whom I know both personally and I consider to be friends. And by me putting this up here, I do not wish to destroy my friendship with them. But they say in a very first line of the first sentence of the paper is transfusion of red cells has saved countless lives owing to, and then they go on with a litany for half a page of why it saved lives. And that opening line is repeated in every transfusion paper I've seen. It's never referenced. There is no reference. There is no way to reference it. It is non-scientific. And when I review papers and I rail against that and I say, prove that to me, I get sent back or asked not to review papers again for that journal. So it is a situation wherein we are promulgating or promoting the same line of thinking, the same belief system, by forcing people who are going to publish anything they must genuflect in front of the dogma. If you don't say the dogma in the opening paragraph, you don't get published. Makes you think. It cannot be proven. It's opinion. It's widespread opinion. It's lore and it's practice. Yet to get published, you have to repeat that gospel over and over and over again. And the scientific right now is profoundly the opposite. Indeed, the opposite is what we have now proved. We've spent billions of dollars proving exactly the opposite, that transfusion doesn't do these things. And PBM has evolved by not directly attacking the establishment. Is that correct? Well, I don't really know, and I can have that philosophical discussion, but we've been allowed to exist, bubble up, and develop because we haven't taken this head on with a wrestling match with the establishment. But why? Maybe otherwise we'd be squashed. Maybe we'd be burned at the stake as heretics. So quality improvement research is now focusing on reducing usage of RBCs and transfusion. There's a huge amount of quality research that's coming out. There's a movement in surgery called ERAS, early recovery after surgery. That's a movement. And I just was a lead speaker at a meeting for ERAS, and I said, why does it astound me that now we have to have societies about doing what I thought we were all supposed to do as physicians, which was provide the earliest recovery for our patients at any possible time? Why do we have to spend money to teach people to do things that make sense to begin with? Wouldn't the lay public like to know that for the last 150 years we've been taking care of things that are easiest for the healthcare system? Maybe most expeditious, but now we have to have a society that actually advocates to get you out of the hospital as soon as possible. Wow, there's something basically wrong with that. So at any rate, in these articles that get published in manuscripts, they talk about reducing usage or dependency upon blood transfusion, or the need for blood transfusion. There is no need for blood transfusion. There is no dependency. It's a human behavior. So those words need to be stricken from our language, and they're part of the bias that shows up in every article that gets published. And by using those particular words, we continue to force the bias upon all of us. The vast majority of this literature that's now coming out in patient blood management supports improved outcomes with the less you transfuse, yet the attacks continue. Attacks continue in the literature against these bits, these wonderful papers. We're all familiar with Western Australia. We're all familiar with the On-Track program in Ontario. The dramatic differences both in cost savings and an improved outcome for those patients. Yet Multiple studies agree that RBC transfusion in heart surgery increases mortality. Ron Salinger, who's at University of Maryland, one of the lead cardiac surgeon at the University of Maryland, is not only publishing on what the prevalence and utilization of blood is in heart surgery in the state of Maryland and what they call the Maryland Quality Initiative. It's much like the state of Virginia. It's much like Ontario. It's much like Western Australia. Now it's catching on that individual states within the United States are looking at their own data. And what does Ron Salinger say? He says that blood transfusion is very tribal. In other words, every group in every hospital has their own behavior patterns, probably driven by the most powerful gray-haired old man that tells everybody else what to do. Maybe he's the most outspoken, or she's the most outspoken or most difficult person to work with. But that drives the behavior. And that's exactly what we saw in 1992 when I published my first article on it. Yes, the overall utilization of blood in heart surgery has decreased, but the discord between those who use the most and those who use the least has still occurred. But here's what Ron Salinger says. There's a 13% increase in 30-day mortality per unit of red blood cells used. 13% increase in mortality. Others have found, there are now 7 publications that I could put up here. Others have found up to 16%. So it's well over 10%. It's somewhere less than 20% increased in mortality, all comers for heart surgery for every unit of blood transfused, and it is arithmetically additive. So the more blood you get, the more death you get. Why is this consistent? Because it's true. We don't need randomized controlled trials to tell us that. We've got multiple bits of data all pointing in the direction. Yet the trick trials and the places where people have tried to do randomized controlled trials because they wish to trump and outplay every bit of retrospective data, they have been unable to either prove it wrong or to prove facts in the other direction. And this is data from Virginia, same kinds of thing. Now let's go to the trials that have been done, because the transfusion establishment says, well, you can't depend on retrospective data. Retrospective data is poor data. It's fraught with all kinds of compounding factors that may drive why you can't come to those conclusions. Except if you go to Bradford Hall's original discussion of evidence-based medicine, if all the data from retrospective flows in the same direction, it is the truth. And that's where we're at today. But now we have trials over and over and over again, and it appears that we're not done with them yet, to be randomized controlled trials. And so the very first one of these was Paul Hebert's original trick trial, which is now so famous. But isn't it amazing that he, in the first randomized controlled trial in critical care, showed that those in the restrictive transfusion group had a significantly lower mortality than those in the liberal transfusion group. So this got widely criticized as, well, you know, was it really the ultimate study? Was it really true? It happens to align with what the retrospective data is, but as soon as this data came out, the people who wish to support the bias and wish to support the thinking and transfusion went on a rampage of doing more and more randomized trials. Here's a review that came out in 2021, I believe, of a meta-analysis of 14 trials. 12 of the 14 trials showed that there's no difference in outcome and mortality in those who are liberal versus those who are not, who are liberally transfused, those who are restrictive transfused. But their conclusion, since 2 trials had a hint, not highly statistically significant, but a hint of an improved outcome. Therefore, we need more trials. So we now have 72 randomized trials, including TRIC 2, TRIC 3, and now TRIC 4 is undergoing. And those 72 trials have been promoted as randomized prospective examinations of patients who get a liberal utilization of blood versus a restrictive utilization of blood. When I have my discussions with these people who are running these trials, they say, hey, we need to know. No, what they wish to know is to find one positive outcome in their entire level of research, of which they can hang their hat on to then say, see, I told you so. See, in this one trial out of 72, 75, 100, 300 trials, whatever it's going to take, we had one trial that showed that it improved outcome. Therefore, all the rest of the literature is useless. Wait a minute, really? Is that science? Is that doing things right? Because, and this is out of the TRIC 3 trial, one small group of patients undergoing cardiac surgery, less than 65 years old, what was called the young ones, and to me now today being over 65, I consider them to be the young ones. Those young ones actually had a tendency to have a lower mortality if they were transfused more liberally than those who weren't. And so they've now proposed the TRIC 4 trial. And I have to ask, what's your definition of futility? We got 72 trials that have been done with liberal versus restricted blood transfusion. Each study has cost, in my estimation, I don't know the cost of each one, but they're millions of dollars to do these large randomized controlled trials. I bet some of them were pushing $20 million to do the study. So now there's 74 because we've got new ones proposed. I put the estimate at close to $500 million US to do these studies to prove to themselves that blood transfusion actually improves outcome. Yet they've been unable to prove that out of 72. How many more do we need? Didn't we need 100? Do we need 500? And if they find one out of 500 and the other 499 show no difference, does that then prove in their minds or in anybody's mind scientifically support for that original sentence that I said in every medical literature? So TRICS 4 is now an international, multi-center, open-labeled, randomized controlled trial of two commonly used transfusion studies in moderate high-risk patients, 65 years old or younger. And this is what's on clinicaltrials.gov and registered. And I've said to the people who are running it, why are you doing this? Well, we have to. I said, we have to. There's a signal there that perhaps transfusion actually does something. So you're on a crusade. You're on a crusade to find some slim piece of evidence that upholds your belief system. Is it possible to actually do this research? Of course it is. The reason I'm told by the people who design these studies that they are doing the studies the way they are is because you can't do a study wherein you withhold blood. So yes, you can. You can do a best of PBM study with the vast majority of those best of PBM patients getting no blood whatsoever and comparing that to standard therapy. Why can't you do that? Of course you can do that. I proposed doing that 4 times. Every time I've proposed doing that, I've been turned down on funding. It's a bias. It's an international bias in everybody's mind that they won't let anybody do it. And I can't just go to the National Institutes of Health in the United States for such a large trial without pilot data. So I need pilot data from 50 to 100 patients in one institution, and I propose doing it in bladder cancer patients for cystectomy. They're all anemic. They all are going to undergo a big blood loss procedure. Why don't we see if we treat their anemia, giving them the best of everything we possibly can in terms of PBM, see if and compare that to routine therapy and look at outcomes. I can write the paper right now, And I can guarantee you those who get PBM and those who get their anemia treated are going to do a whole lot better. So we continue to tilt at windmills. We search for the Holy Grail. Has that worked in 2,000 years of history? Not that I know of, but people still run around and when a popular movie comes out with somebody searching for the Holy Grail, everybody wants to go see it because that's what we're all after. We're all after searching for a Holy Grail. Monty Python did a great skit about it, and it's great comedy, but in the end, it's really very sad. The believing brain continues to try to search for the support of the data that supports what we believe. And to change that is really difficult. So there are no randomized trials of transfusion versus non-transfusion. I just said you can do them. And the people who've proposed the randomized trials that have been performed, they've had every right to change up how those randomized trials are doing. And every one of those comes out and somebody criticizes them and says, well, it wasn't the best trial. There was overlap between the groups. The real separation between the groups wasn't big enough. Well, the people who proposed them had every right to change them to make them correct to begin with, and they've never done it. So medicine is exhibiting a profound hypocrisy, and they're not really looking for the answers. They're looking to support the belief system that they've had founded and are promulgating and promoting and are pushing on our patients to the detriment of humanity. And the biggest assumption is that oxygen delivery is dependent upon hemoglobin concentration. That is wrong. It's not true. And more hemoglobin is not necessarily good, and transfusion actually makes it worse, not better. Harry A. Shander did a fantastic job. I quote this paper. I push this paper to everybody that possibly can. That, yeah, anemia is really bad. And there's one way to treat anemia that's really simple. Let's give them a unit of blood. Your lab data looks better, but the patient is worse. And transfusion decisions are not taught in medical school. Why is this paper not taught as a series of lectures in medical school? I don't know. Listen to Dr. Majed Rafai's lecture on this Bloodless Medicine Society's website. He really looks at oxygen delivery and blood transfusion. Yeah, I could have given the lecture, but he does better. He focuses on it. He goes through all the data, and it's fantastic. Please embrace the society and promote the liberal thinking of that there's another way to look at the world. The storage lesion is a disaster upon the ecosystem. Giving stored blood induces a wildfire within the recipient. I'm not going to go into it in a large way, but tissue oxygen delivery is extremely complex. This is some of my work and some other people's work. Ivo Torres-Fio, Kevin Ward, others, Roland Pittman, great physiologist looking at oxygen delivery. We found that critical delivery of oxygen to tissue is not reached until you are below 3 to 4 grams per deciliter of hemoglobin. Heme dilution alone in my lab to get to that level takes 13 volume dilutions to reach mortality. Yes, you have to hemodilute the animal 13 times. In other words, do an exchange transfusion where you take out red cells and you give them back albumin and saline, and you get them down to below 1 gram per deciliter of hemoglobin. That's when death arrives. It doesn't arrive at 7 grams per deciliter, 10 grams per deciliter. It's a whole lot lower. So I'm sorry when this transpired on my computer, it doesn't all line up exactly right. But this is data that I love out of the Cleveland Clinic and Jehovah's Witnesses. Denton Cooley's work was mentioned. And those patients who refuse transfusion, a human experiment, by and of themselves saying, you know what, I'm going to opt out of this therapy. They do better. And so let me get to the end here. because I think I'm starting to run out of time. Mother Nature is biologic complexity. Red cells are affected by oxidative stress, and red cells don't do well when you leave them in the refrigerator and they undergo oxidative stress and they get worse and worse and worse. And when we give them, it's not just the immune system, it's the fact that you're giving oxidatively stressed red cells that just can't possibly function well. So the key to bloodless medicine is never let a patient get near either the fatal hemoglobin or what I say is the fatal hemoglobin, which is the hemoglobin that triggers the behavior pattern in the human who's going to call the blood bank to give the blood transfusion. In other words, treat the anemia, do all the things you can to keep away from that dependency. There's that bad word, dependency upon blood transfusion. They all do as well or better until you get shock. In other words, extremely low perfusion, extremely low ability to move plasma and to perfuse cells. And let me go to my last point and I'll take questions. There's a worldwide need for a safe liquid oxygen carrier, what we used to call a blood substitute. Several are available. Large human trials have been done. I believe Russia has one, though I'm not exactly going to go ask anybody over there right now. I know China has one. China has a perfluorocarbon because I know they grabbed one that was being investigated in the United States. But US regulatory and European regulatory groups have refused to find a way forward to do the research necessary for when blood is not an option. And I've personally pushed high with people very highly connected, both inside the United States government, and it's actually been on Vladimir Zelensky's desk to get one of these products up to the front lines of the Ukraine. So far that hasn't happened, but maybe I'm not done yet with that. And the emerging world that is struggling to try to promote Western blood banking could utilize these technologies absolutely. But it's the transfusion bias that's killing human beings. It's the transfusion bias that I talked about so far that is not allowing us to find ways collectively to do the research to prove that these are either necessary, useful, etc. But it is that bias in the believing brain across all of medicine that somehow we have to attack. I've always been a heretic, you know that. I said this last year. So far, I haven't been burned at the stake, but I've been labeled all kinds of things. I've been told to my face I'm a fringe element. You, sir, are a fringe element. Okay, you want to define that? If that's what you want to define, fine, I'm a fringe element. I like my fringe element. I like speaking my mind. I like trying to look in that mirror and say, can you say that with truth? What is truth? Is truth just what I believe? Or is that something that, scientifically I can prove? So heretics attack institutions that are on shaky ground. The utilization of blood for the vast majority of places that it's utilized is on very, very shaky ground. Read Arias Shanders and other people's analysis of how often blood products meet standards of care. Those are today's standards of care. Those are not. So there's only 15% or so of all transfusions that meet present day standards of care. What about the other 15%? Were they really necessary? Or were they just ones that we couldn't improve? Bloodless medicine must be our goal. And I'm going to leave you with this thought. And take this thought for all the rest of the lectures. And it goes to the believing brain. Faced with a choice between changing one's mind and proving that there's no need to do so, almost every one of us gets busy going on the proof. John Kenneth Galbraith. What do we believe? What's truth? And what is and what could be accomplished. So I believe strongly that bloodless medicine is our goal. And to get there, we've got a whole lot more education and a lot more looking in the mirror for every last one of us. Thank you.